Hey, Nikki? Nikki?
Yes.
Oh, just making sure. I was going to try to go without my headset. Can you hear me okay? Or should I use my headset?
Actually, I hear you loud and clear.
Oh, okay, perfect. Thank you.
Okay, with that, we will go ahead and get started. Thanks for joining us for this media briefing about COVID-19 in Idaho. My name is Nikki Forbing-Orr, and I'm going to be the moderator today. Please note that everyone should be muted unless they are speaking. ASL interpretation is available today. If you search for the window for interpreter stubs and hover over the three little dots to the right in the video window, you can lock it in place on your screen so it's always visible. For the briefing today, we're going to have remarks from several people to get us started. Health and Welfare Director Dave Jeppesen will begin, and then we will hear briefly from Public Health Administrator Elke Shaw-Tulloch, State Epidemiologist Dr. Christine Hahn, Idaho Bureau of Laboratories Chief Dr. Christopher Ball, and Deputy State Epidemiologist Dr. Kathryn Turner before we open it up for questions from the media. Idaho Immunization Program Manager Sarah Leeds also is participating today. And with that, I will turn it over to Director Jeppesen.
Thank you, Nikki. Appreciate that. This week, we are changing our press briefing to be about COVID-19 overall, not just COVID-19 vaccines. As part of this change, in addition to opening comments from Elke and myself today, as you just heard, we'll have opening comments from Dr. Chris Hahn, Dr. Chris Ball, and Dr. Kathy Turner. Since early February, our statewide 7-day moving average of cases per 100,000 has leveled off and been between 15 to 20 cases per 100,000. Although still higher than we would like to see, it has been good to see the case rate remain fairly steady. We continue to see an elevated case rate in eastern Idaho, but those case rates have been level or declining recently. For the last 6 weeks, we've seen the COVID-19 testing positivity rates hover right around our goal of less than 5%. It has been good to see the positivity rate be stable and right around our goal. However, we remain very concerned about variants. We know that we have variants in Idaho, and some are more easily transmitted from person to person. We are grateful for the many Idahoans who are choosing to take actions such as wearing a face mask and physically distancing, as their choices continue to make a difference. For the last 2 months, we've seen the number of hospitalizations for COVID-19, including ICU stays, be at a level that we had not seen since September last year. However, there is a small upward trend for hospitalizations over the last 6 weeks that leaves us concerned. I'm happy to report that the number of long-term care facilities with active COVID-19 outbreaks has declined from over 200 back in December to just 60 facilities today. And on the vaccine front, as of yesterday, anyone 16 or older who lives or works in Idaho is eligible to get vaccinated. For those over 65 years old, 69.1% have received at least one shot. This is great news, but we would like to continue to see those numbers go up so all of our most vulnerable citizens are protected. And for those 55 to 64, 43.7% have received at least one shot. This is good progress, and we hope to see younger adults and older teens choose to get vaccinated as well. All 3 approved COVID-19 vaccines are safe and effective. We are encouraged by how many Idahoans have already been vaccinated and appreciate all those that will choose to get vaccinated who haven't already done so. And with that, I will hand it over to Elke.
Thank you, Director, and welcome everyone. I have a couple of things that I wanted to touch base with you on today. First is about long haulers and give you an update on that. And then also I want to talk about the new CDC guidance for fully vaccinated individuals and travel. So to start, I wanted to let you all know that the department, if you haven't already seen it, the department has had a request to provide information on long COVID, also known as long haulers. So we placed some information on our website recently. Long COVID symptoms can include things such as fatigue, shortness of breath, brain fog, sleep disorders, fevers, gastrointestinal symptoms, anxiety and depression that can persist anywhere from months and can range from mild to incapacitating symptoms. And there's still, we want to make sure that everybody's clear, there's still a lot that is unknown about long COVID and the long-term effects of COVID, but studies are currently underway to address this issue. And we've posted some of those studies on our site. One of the notes that you can see on there about the studies is one from the National Institutes of Health. It was an initiative that was announced on February 23rd to study long COVID. And the designers of this study hope to learn about the spectrum of recovery from SARS-CoV-2, which is the virus that causes COVID-19, the number of people that have long COVID, the underlying causes of prolonged symptoms, what makes some people vulnerable to the virus, and if the virus can trigger changes in the body, putting people at increased risk of other conditions such as chronic heart or brain disorders. So the department site also includes some links to support groups for people with long COVID. And there are several social media groups that can connect people all over the world to discuss their symptoms, experiences, coping mechanisms, and possible treatments. We really look forward to any additional information those studies can bring to light around long COVID, and we'll continue to update our website as we learn more about this condition. The other thing I wanted to talk about was the new CDC travel guidance. As you recall, we've talked about it in previous briefings, the Centers for Disease Control and Prevention published guidance for people who are fully vaccinated. Part of the recent updates to that guidance were around travel. So they do talk about people who are fully vaccinated in both domestic and international travel. And they state that people who are fully vaccinated can resume domestic travel and do not need to get tested before or after travel or self-quarantine after travel. Fully vaccinated people do not need to get tested before leaving the United States for international travel unless it's required by that destination. And the same holds true for domestic travel, actually, or for self-quarantine after arriving back in the United States. We do encourage that you check your destination to see if a test to enter that destination is required. And CDC is also recommending that people get tested 3 to 5 days after international travel. After any travel, both domestic and international, you should self-monitor for symptoms. However, we continue to stress that non-essential travel should continue to be limited for extra precaution. We are not out of the woods yet, as we've talked about before. And if you must travel, make sure that you wear a mask, that you stay 6 feet apart and avoid crowds to the extent possible. You continually wash your hands or use hand sanitizer. So as any of these changes come to us further from CDC, we'll certainly bring those to your attention. But you can also find those travel guidelines on the CDC website. With that, I'm going to turn it over to Dr. Hahn.
Thank you, Elke. Thank you, everybody. I'm going to just give a super quick update in there. I know there might be questions about some of the vaccine changes to the vaccine rollout that will affect Idahoans. And I'm very happy to say I just got a text from my husband that my daughter just got my 17-year-old daughter just got her first dose of a Pfizer vaccine. So I'm personally very excited about that today. Clinical trials for kids are ongoing. You might be aware that Pfizer and Moderna now have announced they're in phase 3 trials down to age 12. And actually, they also have earlier stage studies going on in children as young as 6 months. So we're very excited to see that those studies are moving forward. Pfizer is actually expected to file for an emergency use authorization sometime this month, possibly, for 12 to 15-year-olds, with the goal that they have stated of having vaccine available for these younger adolescents, I guess 12 to 15, before school starts next fall. So we'll see how that rolls out, but certainly a lot of optimism there for starting to get kids vaccinated before the next school year. In addition, we know that AstraZeneca is going to file, or has announced they are planning on filing for emergency use authorization. I have not seen that has actually happened yet. It was supposed to happen late March, early April. So I'm certainly keeping my eyes peeled, but that will be interesting. We all are aware AstraZeneca has had some stumbles going forward. When they initially announced that they were planning on filing, they immediately had some pushback about the data that they had submitted not being completely up to date. So I think they've corrected that, and I think that will be moving forward. So stay tuned on that. We're very pleased about the information that's coming out against the variant strains for Pfizer and Moderna. Both have some data now suggesting that their vaccines perform well. However, I just learned today that I think it was announced a few days ago, but that Moderna is actually starting phase 1 trials. So that's just the very initial safety trials for a vaccine designed specifically against the South African variant, just in case their vaccine does not hold up once the South African variant has more of a chance to be really tested, if you will, to test that Moderna vaccine. So they are starting to get those vaccines into early clinical trials in case they're needed against the variants. So that's very interesting. I just wanted to finish up my conversation about the vaccines with a comment or the reminder that people are aware, of course, that Johnson & Johnson had some production problems. Mistakes were made in a plant that was trying to come online. But a few quick points about that. And I'm speaking partly from personal experience. I was at a clinic administering Johnson & Johnson vaccine over the weekend, and I was asked, well, boy, is this possibly contaminated, or is there something wrong with this vaccine? The Johnson & Johnson problems were at a plant that was not yet in production. So the Johnson & Johnson vaccine being used in Idaho and elsewhere in the country are not impacted by this. They were all produced at their Netherlands plant, not at the United States plant that was trying to come on board. And you may be aware that that plant was also going to do AstraZeneca vaccine for them, but now that's been separated because there was a mix-up between the two vaccines with how they were being manufactured. So Johnson & Johnson has stepped in. They're going to take over that manufacturing, and AstraZeneca vaccine will be manufactured elsewhere. So certainly some challenges with these vaccines, but all in all, really good news as far as the safety. The director already alluded to the fact that these vaccine rollout is actually going amazingly well, and the vaccines are safe. We're having good experience here in Idaho and in the rest of the nation with them, and we look forward to the new data coming out on the younger age groups and for AstraZeneca, of course. So I'll leave it with that, and I'll turn over to Dr. Ball, who's going to talk about the state's efforts to detect variants.
Great, thank you, Dr. Hahn. Director Jeppesen asked me to bring a couple of updates to the group. First, a brief testing update, and that is that last week the FDA authorized new antigen test systems for non-prescription over-the-counter use. We anticipate that in the coming weeks that these will become available at retail pharmacies, and as we learn more information, we'll be sure to share it with you. These tests are going to be really helpful as we look to augment our current largely PCR-based testing strategy. In particular, these new antigen tests are intended for the use in serial screening of asymptomatic individuals. So serial screening is when an asymptomatic person tests multiple times a week, so at least 2 times a week. One of the issues that we've seen with antigen tests is that they tend to be a little bit less sensitive than PCR. And the FDA feels that if you have multiple tests in a week, you can overcome that sensitivity limitation. And where we think that this will be really valuable is it'll be a great way for us to stop the silent spread that's associated with asymptomatic infections. So more information to come on that as those products start to hit the shelves. The testing task force is currently revising our antigen guidance to account for these new changes, and that will be published on our coronavirus website coming soon. So with that brief testing update, I think I'll turn over to a sequencing update. But before I discuss CDC's and Idaho's efforts to expand our SARS coronavirus 2 whole genome sequencing process, I thought I'd quickly review how the whole thing works. So the process starts when a person tests positive by a PCR test. So the leftover sample from that positive PCR test is forwarded to a sequencing lab, which can be out of state or in state. And that if in that leftover specimen the RNA, the viral RNA in that sample is of sufficient quantity and quality, then we can generate a sequence. So that sequence is literally the assembly of about 30,000 RNA bases long, and we take that assembled 30,000 base pair sequence and we compare that to a database. And once that comparison with the database is made, a lineage is assigned to that sample. The lineage is generally designated for SARS-CoV-2 as a letter and number designation, so like B.1.2. And in some instances, you'll also see the origin of where that particular lineage was found. So after the lineage is assigned, then that sequence is uploaded into a public database where it can be accessed by public health and professionals and researchers. And that research and public health work is where we take certain lineages and match them up with clinical case information. And then sometimes we'll find that certain lineages will have characteristics that are worrisome. So they'll have increased transmissibility or increased severity of disease or resistance to certain treatments. And when we find those lineages that have those kind of worrying characteristics, then they get identified as either a variant of interest or a variant of concern. And CDC has definitions for all of these different levels of variants on their website. So one of the things when we start looking at our surveillance program, what we're trying to do is we're trying to do two things. There's a national effort being led by CDC that is looking to try to figure out what types of lineages are circulating in the state and how many of those are variants of interest or variants of concern. In Idaho, our state level program is really concerned about identifying variants in Idaho. So these variants are the lineages that can be associated with more complications of COVID-19 disease. So because of that, we sent out about a month ago a request to all Idaho clinical laboratories, and those that are performing PCR, we asked them to send us at least 5 and more if they have them, samples to us on a weekly basis. But we said, we want you to prioritize them for samples that may be more likely to identify a variant. So those would be samples where you have case information that indicates the person was fully vaccinated, what we call a vaccine breakthrough case. We're also interested in some samples that have a particular PCR signature called an S gene target failure, which may indicate that it is the variant that originated in the United Kingdom. We're also interested in folks that have reinfections, so that at one point earlier in the outbreak, they got infected, and then some distance later, they got infected again. And then if they don't have any of those, then we said, just send us kind of a random sampling of the population base that you're seeing. So at the Idaho Bureau of Laboratories, we're prioritizing these samples that are more likely to be associated with being a variant, but we're also taking the sort of random routine samples and we're submitting those to the CDC to help bolster their efforts to describe what's going on nationally in the country. And on their website, they publish data that shows the frequency and number of different types of lineages as well as variants of concern that are currently circulating. Here in Idaho, we take all of the samples that are uploaded into those public databases, we query those on a weekly basis, and on our coronavirus website, we list the total number of Idaho samples that have been sequenced and the total number of variants of concern that have been detected. It's really important to note, though, that the samples that are being sequenced in our laboratory at the Idaho Bureau of Laboratories or being sequenced by our partners are really heavily biased towards detection of variants. And so the numbers that we post on the coronavirus website cannot be extrapolated to be representative of what may be circulating in the state. So I think the key takeaway is interpret the data with caution. We're working on ways to make that data a little bit more accessible and a little bit more understandable. And we currently have a working group with the testing task force that's looking specifically at that problem, how to make this data more accessible and more understandable to the general public. So I'll turn it over now to Dr. Kathryn Turner, who can give you a little bit more information about the types of variants we've seen in Idaho and also some of the case information associated with those. Kathy?
Thanks, Dr. Ball. Yeah, I would like to briefly describe a little bit about what we know about the people who have been identified as having an infection with the SARS-CoV-2 variant of public health concern. So again, to reiterate what Dr. Ball stated about the data not necessarily being representative of the general population because of how those specimens are being prioritized for sequencing, we can describe symptoms that have been reported in the course of illness among these Idahoans without jumping to conclusions about generalizing to the rest of the population. So there are still cases being investigated, but among those with known symptom status, 100% have reported symptoms. In general, when we have the symptom status about a case of COVID-19, approximately 10 to 15% report no symptoms. So what we're observing among the cases infected with variants of public health concern, at least with regard to symptoms, is a little bit different than what we've observed with cases investigated throughout the outbreak. About 4% have been hospitalized and 1% have died. And these percentages for hospitalization and death are similar to what we've observed throughout the outbreak with cases that we assume are infected with the wild type virus. But again, we're not jumping to any conclusions at this point because we have so few cases. And the genetic sequencing testing has been very targeted. So it's difficult to make generalizations until we have more data or our genetic sequencing testing is more broadly available. I will tell you that the most common symptoms that have been reported among these cases are headache, fever, cough, sore throat, and fatigue, and about a third of them also report shortness of breath or difficulty breathing. 4 of the cases that were infected by a variant of public health concern were also fully vaccinated at the time they tested positive. So as Dr. Ball mentioned, these are our vaccine breakthrough cases. These are cases of SARS-CoV-2 infection that have been identified in people no sooner than 14 days after their vaccination has been completed. So this is either with the 2-dose series of Pfizer or Moderna, or 1 dose of the Janssen or Johnson & Johnson vaccine. The 4 cases that were infected by a variant of public health concern and also fully vaccinated at the time that they tested positive were determined to be infected with the B1427 or B1429 variant. This is also known as the California variant. Right now, we have 109 cases that we have been investigating of vaccine breakthrough infections. This does represent about 0.03% of fully vaccinated Idahoans, so a very small percentage. 57 of those people received the Pfizer vaccine, 49 received the Moderna vaccine, and 2 received the Janssen vaccine. 1 case, we are still confirming the brand that they were vaccinated with. Among the 90 people that public health has been able to interview for their with these vaccine breakthrough cases, about half report no symptoms at all. Of those who did experience symptoms, 40% had very mild symptoms that were described as symptoms you would see in a head cold or allergies, such as congestion or a headache. 50% had moderate illness, so these are like flu-like symptoms, and 3 people were hospitalized. All 3 of those that were admitted to a hospital did have a medical condition and other risk factors that put them at very high risk for severe disease. I will note that 10% of the vaccine breakthrough cases that have been investigated were among people that had a condition that would have compromised their immune system, and we're investigating whether or not that had something to do with the vaccine breakthrough. We continue to work with Idaho providers and our local and national laboratories to monitor those infections with virus variants of public health concern and infections among those who are fully vaccinated, and we'll continue to update you as our response continues. And with that, I'm going to turn it back over to you, Elke.
Great. Thanks, Kathy. And I'm actually going to turn it back over to Nikki.
Oh, thanks. Yeah, actually, so we've given you a lot to think about here, and we will now take questions from our media participants. We're going to answer as many questions as we can in the time we have available today. Please raise your hand in WebEx by selecting the hand icon in the lower right portion of your screen. You can also type your question into the chat area, which you can also access in that lower right part of your screen. When I say your name, please unmute yourself and announce your name and media outlet before asking your question. And also, I would ask that you please remember to clear your hand when you're done. All right. I'm not sure who got their hand up first, so we'll start in alphabetical order with Audrey Dutton.
Good afternoon. I am wondering if you're seeing any demographic changes in who is getting the vaccine relative to who's eligible at this point. From what I'm hearing from providers, there's less uptake among the younger groups, even though they're eligible now. So fresh out of the gate, you know, just not as interested seemingly. And I'm wondering if you're seeing that bear out in the statewide demographic data.
Yeah, thanks, Audrey. It was a little faint, so I think I got everything that you were talking about. I'll get going on this, and then I will turn it over to Sarah Leeds, who's on the phone as well. Certainly, as we all know, the general population was just opened up this week. So starting yesterday, age 16 and older could begin receiving the vaccine if they weren't already eligible in a different population group that's previously been vaccinated. So, of course, we do expect to see a little lower uptake in the younger age groups because they haven't yet been eligible until just recently. So I would say that we're seeing kind of what's to be expected. We still want to continue to push hard to make sure that everybody who wants to get the vaccine gets the vaccine, and maybe some different messaging needs to be made available for different age populations, of course, and appeal to different types of things that get people to take action, I guess that's what I'm trying to say. But I would turn it over to Sarah if she wants to give an overview of the age ranges that we're seeing and kind of the uptake that we're seeing.
Yeah, thanks, Elke. So right now, when we look on the dashboard, which is current through IRIS data at the end of yesterday, so it's pretty current. In the 16 to 24 age group, we've got less than 30,000 showing vaccinated, 13,000 vaccinated. And so that's a really small number of the total population, especially given that, you know, technically, unless they had a health condition, yesterday was the first day they would have been eligible to be vaccinated as 16 and over. So I think, you know, the data that the age group breakdowns are on the vaccine dashboard, and you know, they're 19,000 have been administered to 25 to 34-year-olds, and so we're really, you know, like Elke said, looking to implement marketing and education efforts that really resonate with those age groups, and they're different for different age groups. So those are the things we're focused on now that we're fully open to all populations.
Thank you.
All right, we'll move on to Chase Biefelt.
Thank you, Nikki. So my first question, I can ask another one later on, but it's focusing on the variants here in Idaho. It's kind of a two-part question here. Are we behind where we need to be in terms of getting people vaccinated, and how quickly or lack of speed that these variants are spreading? And is one variant of more concern than another in Idaho right now?
Thanks, Chase. I'm going to turn that over to Dr. Turner, and maybe she can start with the variants themselves and then kind of back into where we're seeing the vaccine in comparison.
Yeah, thank you. So great question. All of the variants are of concern. We are in a race against the variants with our vaccination program. Let's just cut to the chase. Every single time that virus is transmitted, it has a chance to mutate. So the faster we get people vaccinated, the better off we'll be, the fewer variants we'll have. The vaccines are effective against the variants. you may have seen our data. B117 is the most commonly identified variant in Idaho right now. This is that UK variant. But vaccine manufacturers are looking at boosters or looking at efficacy with regard to their particular vaccine and its effectiveness against variants. That being said, Dr. Hahn is our resident expert on vaccines, so I'm going to defer to her to see if she has anything to add about the vaccines and the variants.
Yeah, thank you. I think you answered that exactly correctly. As Dr. Ball reminded us, we can't really conclude a lot from because of the way that we are sampling. But we do have at least that one large provider that is sharing with us that he is seeing a lot of the lab indications that he's got a lot of that B117 UK going on. And this is particularly concerning because we do know it is more transmissible and it is also suspected to be more severe. So I'd say if I had to pick one right now, it's probably that UK strain, the B117, but that doesn't mean it's going to stay that way because, as you mentioned, it's a constantly changing story.
Okay. We'll move on to Kyle Fonensteel from the Post-Register.
Thanks, Nikki. I wanted to ask about vaccinations in long-term care facilities. I know the state has some difficulty with tracking like the rates of residents inside long-term care facilities that are vaccinated. I'm wondering what powers the department might have to require specific facilities to tell you how many of their residents are vaccinated or their staff are, and if you're exploring doing anything like that.
Thanks, Kyle. It's a great question, and I'm making sure that everybody has a turn answering questions. So I'm going to turn it over to the director and see if he wants to take the first stab at it from the policy standpoint, and then we can fill in the rest with other folks.
Thank you, Kyle, for the excellent question. Our biggest indication that we've had some success in the long-term care facilities, as I mentioned earlier, is we're seeing a pretty dramatic drop in the number of active outbreaks that are going on in facilities, and that's been a steady downward decline ever since vaccination started. As you mentioned, we actually have, we don't have a systematic way to gather what vaccination rates are at long-term care facilities, and that's both from a data capture perspective of what goes into IRIS, but perhaps more importantly on that is there is quite a bit of fluidity at long-term care facilities, both with residents that come and go, but even more importantly with staff that come and go. And so it is difficult to sort of measure. You get sort of a point in time, but it changes pretty quickly of what the staff and resident situation is. And so that presents some challenges for us to really understand what the vaccination rate is among the long-term care facilities. But we are very encouraged by some of the anecdotal feedback that we hear. We do know that many of the facilities are reporting, or when we just casually talk to facility owners, are indicating that a large number of their residents have been vaccinated. They are obviously encouraging residents that are new to the facility to, if they're not vaccinated, to get vaccinated. Obviously, it's their choice, but are encouraging that. And that actually it's paid off quite well. I'd say we have less visibility into what the vaccination rate is among long-term care worker staff. And I think I'll leave it at that.
And Director, I know Dr. Hahn has been working with the long-term care strike team to do some survey work too. So I'll turn it over to her.
Yeah, thank you. As the director said, we don't have a real easy way to do this, but the long-term strike team long-term care strike team has done a survey of those facilities, asking them to just voluntarily report. We're not collecting that information facility by facility, but just as an overall by type of facility, so skilled nursing and assisted living. And I was allowed to see some preliminary results. I think the results are still coming in, but we hope to have some good information on that. And it's a very important question. It's a really great question because what we've seen is that in general, and we're hearing around the country, residents have a fairly high rate of uptake. 80% or more of residents are getting vaccinated, but it's really the staff that has more hesitancy and is not getting vaccinated at a high rate. And we're suspecting we'll find the same in Idaho. And so what that tells us is we need to do a better job of working with the long-term care facility staff and seeing what their concerns are. And that's one thing the survey is getting at, is what are their concerns? Why are the vaccination rates not where we'd like them to be? And I hope that it really helps us move forward.
Okay, our next question is going to come from Melissa Davlin.
Thank you so much, Nikki. This is Melissa Davlin with Idaho Public Television. First of all, thank you, Dr. Ball, for that explanation of the samples that are sequenced for the variants. I had a question based on that explanation. You said that the people at the lab identify which samples have enough both quality and quantity to sequence for the variants. And so, forgive my rudimentary question, but is there any talk with providers about changing the way that they collect the samples to make sure that there is more, nose gunk on the Q-tips so that they actually have more to sequence and more to test to actually get a better picture of the spread? Or is it more complicated than that?
Well, thanks, Melissa. Unfortunately, it's a little bit more complicated than that. So really the factors that go into getting a good quality sample for sequencing, what we found is it's oftentimes the way that the samples are handled between the original submission and when they get to the sequencing laboratory. The faster those samples can get into a freezer, the more likely we are to see them have good quality success upon sequencing. So it's a number of factors that are at play. It's both the amount of viral RNA that's in the sample, but that RNA also has to be of a high enough quality that when we go to sequence it, we can actually assemble that sequence into useful information. And so we've been working with the laboratories that are submitting samples to us to try to encourage them to get those leftover samples into a freezer as quickly as possible. And then we're also providing an opportunity for them to ship them to us frozen in an effort to try to increase the number of samples that we can successfully sequence. The other thing that I'll add is I know that there's been a lot of questions about sequencing around folks that are vaccine breakthrough cases. And one of the things that I've heard and discussed with some of our colleagues nationally is that oftentimes on those samples where people test positive after completing their vaccination series, those samples tend to not be as successful in sequencing because it doesn't appear that they have as much virus in the sample as somebody who hasn't been vaccinated. So in general, we've seen kind of a higher failure rate in those vaccine breakthrough cases for sequencing. I'm not sure if that fully answered your question.
It does, thank you. So as you are talking to these laboratories about, here are the best practices to make sure that we get a high quality sample, are you starting to see more successful, sequencing attempts?
I think it's a little too early to tell. The program is still relatively new, and I think as we get more time under our belt and more partners locally sequencing, I think we'll be able to better answer that question. It does definitely appear to be an issue of both sample handling as well as the quantity of viral RNA in the sample. And so we'll try to do whatever we can with providers to try to assess that. But the first thing that we do when we get a sample in is we actually retest that sample before we start putting it into the sequencing process, just to make sure that we think it will be successful. And if we see particular providers that are giving us samples that don't look likely to be successful, then we do a little bit of targeted outreach with them.
Thank you.
All right. Our next question is going to come from Nicole Foy.
Hi, Nicole Foy from the Idaho Statesman, and my question is regarding the $20 million that Idaho is due to receive from the American Rescue Plan to increase vaccine uptake and access among racial and ethnic minorities. And I'm wondering what are the discussions with the CDC about implementing these funds in some of these areas, and are there concerns about successfully measuring the success within those parameters, given Idaho's pretty limited race and ethnicity data that's available for vaccine uptake?
Thanks. Yeah, we are working with CDC as every grant opportunity that comes to the state. Well, in this case is a cooperative agreement. They do have specific guidance that we must follow in implementing these grants. And they do have some specifications in there about how much money needs to be dedicated to certain population groups and targeted areas. So I feel, I'll just at the highest level, I'm going to turn it over to Sarah Leeds after this, and she's the manager of that grant. But at the highest level, certainly we feel that there's an ample amount of money that will help us be able to work with the health districts, with the tribes, with other community partners to help us do a more robust job of targeting our efforts, making vaccine, as we talk about it every single week, we want to make sure that the vaccine gets to people where they are. So this will help us in those efforts. It will help us provide more mobile clinics or other type of mechanisms that will get the vaccine to the people where they are. And then we'll be able to also, of course, then measure how much vaccine can get out locally to certain populations. But I'm going to turn over to Sarah with what some of the actual guidance is from CDC.
Yeah, thanks, Elke. So we do, as you probably know, we have the $20.7 million, and we have some pretty, as Elke said, prescribed, there are required activities because it's not a grant, it's a cooperative agreement. And those are, kind of some semantics in the grant world, or well, outside of the grant world, but we have some required activities. And then we are also allowed to propose additional activities with those funds. And we just got the official notice of those funds last week. And so we are in the process of making the formal acceptance of those funds and then developing the budget and the work plan for those funds. But we do know that 70% of those funds are required to be dedicated to efforts that increase vaccination in vulnerable populations. And so kind of across the board, that's, racial and ethnic minority groups, persons with disabilities, people in hard to reach locations. So we are looking at a lot of different activities that will help us reach all those folks. And then we also know that 60% of those total funds are going to be dedicated to local level partners. So it's really a lot of money that will go through the state and be implemented at the local level with health districts and also maybe some non-traditional partners and community organizations and groups to work together to increase vaccination.
I just have a quick follow-up. I know that especially when it comes to increasing vaccine access for racial and ethnic minorities in the state, that local health districts and other people working with federal partnerships like Terry Riley, for example, have certain methods. But I'm curious, what's working right now when it comes to state efforts from the state? What that you might be expanding upon with some of these funds?
Well, that's a great question. One of the things we're really looking at is mobile vaccination and what we can do as a state to bolster efforts at the local level to increase mobile vaccination. It is, as you get more and more rural, it is more expensive to administer a vaccine, but that doesn't make it any less important. And so it's costly for providers to do that, but it's also necessary. And so we're looking at ways we can partner to be really efficient at perhaps not just delivering vaccine in a mobile clinic, but other services as well. And so those are some of the things we're looking at right now. And I'm quite confident that there's some ideas out there that we haven't even thought of yet, or that other folks have that we haven't heard of. So.
Okay, we'll go to Joey Prechtel next.
Hi, wanted to ask specifically about the trend the state is seeing in COVID-19 cases. Basically wanted to ask is what is the state seeing in terms of, are we still seeing the same percentage of Idahoans 65 years and older, catching COVID, being hospitalized, and so on and so forth, or, the daily cases that are reported every day, are those coming more and more from the younger ages that have not been eligible for the vaccine as long as those Idahoans 65 years and older?
Yeah, thanks for the question, Joey. And I'm going to turn it over to Dr. Kathryn Turner, as she is the one that looks deeply at all of those data daily.
Hey, hi, Joey. Good question. So you hit the nail on the head. We are seeing a gradual decrease in the average age of people who are identified as a case of COVID-19. It's been a gradual decrease, but we're looking at about a year, week to week, moving from 37 years on average to 36 years. Last week it was about 35 and a half years. So the cases themselves, yes, are decreasing in age.
Follow-up, what about hospitalizations?
Knew you were going to ask that follow-up. Yes, hospitalizations have also been slowly decreasing in the average age. Again, these are gradual decreases. I mean, it's not like it went over a cliff or anything like that as far as the trend goes, but we are seeing a gradual decrease in the average age of people who are hospitalized. We're seeing an average decrease in the average age of people who are identified as a case.
Okay, we will go for a round of second questions here. We'll start with Chase Biefeld. Oops, Chase, I think you're muted, maybe? Yeah, we don't seem to be able to hear you. No, sorry.
We can try the chat.
Yeah, maybe put your question in the chat. In the meantime, we'll give you some time to type that in. We'll move on to Audrey Dutton.
Question is for Dr. Ball, and I'll speak up. Sorry, it was quiet before. People, I think, are wondering, is a variant of concern spreading in my community? And I know that the sequencing, a lot of things have to go right to get a variant confirmed. But what can you tell us about where we are seeing the variants? And if you're getting the data from the various labs around the state that are able to produce it, what are you seeing in terms of the kind of suspicious samples, the S gene drop-off cases? Could you give us a geographic kind of breakdown, and when will that kind of information start coming out to the public?
Thanks, Audrey. Yeah, I can give you a partial answer to that. Of the almost 500 samples that we know about that are Idaho cases, we have only a fraction of those we have regional information on currently, so about 40 to 45%. The one thing that I can tell you when we start looking at the samples that we do have regional information for is that it appears that in every region of the state, so in northern Idaho, southwest Idaho, central Idaho, the kind of the Magic Valley area, and in eastern Idaho, we've detected both the UK variant, the B.1.1.7, and also the California variants, the B.1.427 and 429. And so what we can say is we feel fairly comfortable based on the information that we have right now that those two variants of concern are probably circulating in most communities through the state. And when we look at the national data presented by the CDC, what we're seeing is an increase in the proportion of the B.1.1.7 and the California variants nationally. So the trends we're seeing in Idaho are similar to what are being seen nationally using that sort of representative database. So with regard to making that information available, I'm actually working right now with Dr. Turner's group to try to add some regional information onto our coronavirus website so that when we update the total number of sequences and the total variants of concern identified, we can attribute those to regional portions of the state. Unfortunately, it's a relatively complicated data set to work with, and so that's why we formed that work group from the Coronavirus Testing Task Force to get some additional minds in the mix and some recommendations from those folks on how best to display that information so that people don't draw the wrong conclusions. In that work group, we anticipate having infectious disease physicians, epidemiologists, as well as laboratorians. So I think in the coming weeks, you should see some both regional information and then also some broader information about the types of lineages we're seeing in the state. Did that answer your question?
It did, yeah, thank you.
You're welcome.
Okay, I've got Chase's question here in the chat. Boise State University doctoral students showed research earlier today in their vaccine briefing that we are on track to reach herd immunity by December. I wanted to get some perspective from the state. Does this seem fair, or could it be sooner or later? Could variant cases affect this timeline?
Having not seen that information that BSU has published, there's a lot of information that can go into those studies, of course, that we are unaware of and assumptions that they made. I know that Dr. Hahn has addressed this question in the past about when we expect to see herd immunity. So having practiced that response multiple times, I'm turning it over to Dr. Hahn again.
Yeah, thank you, Elke. A couple things. First of all, of course, the definition of herd immunity is not established. So there's no firm, I'm sure Boise State picked one and justified why they used their number, but as Elke mentioned, it'd be great to see that information. It'd be kind of nice to see the work they've done. And we will ask them for that actually. Secondly, how long it's going to take is very tough to say because, of course, it depends on if our current rate of vaccination continues, increases, or if we see a flattening off of interest and vaccination efforts. Also, the herd includes children, and right now there are no vaccines for children. So it's very hard to predict when we'll reach true herd immunity when we don't know yet when those kids will even have the opportunity to get vaccinated. I'm sure, again, they made certain presumptions for their model and their discussion, and they were probably very reasonable ones. But I actually want to mention that on our vaccine dashboard, you can actually play with those numbers yourself. There is a little element to that tool where you can kind of look at some of those factors and say, well, let's say we're aiming for 70%. At our current rate, how long is it going to take us to get there? So certainly there's a way you can look at that. I will mention, speaking of Boise State, that we actually just today, actually I think yesterday, just got some results from them. They actually helped us out with a mask study as well. Some of you may recall, I think there was some period of time months ago that I talked about that a lot. I was out on the weekends, haunting the grocery stores and so forth, trying to do informal mask counts. And Boise State did a very nice mask study. And I don't know if you heard any of that today and if they did some presentations, but we've asked them to present that to us formally as well, just looking at the rate of mask use in different communities around the state and so forth. So we're really happy that Boise State has done the work that they're doing and is supporting us and would love to see their estimates of herd immunity as well.
Okay.
So I see Chase just said they put 60% in as their, again, and for current thinking, that's probably on the low side for herd immunity, but it'd be really neat to see their estimates. Thanks, Chase.
Okay, we have another question in the chat from Karen Bosick, who writes for Eye on Sun Valley. And her question is, are you concerned about more Idaho kids going back to in-person school, given that young people seem to catch the variants more than they did the original novel coronavirus?
Yeah, Dr. Hahn, do you want to continue on with that? You've been
Sure, and there may be others that want to chime in, but yeah, what I would say is, of course, we are concerned and we continue to recommend safety measures, including the wearing of masks and as much distancing as possible. We're aware that not all schools can bring kids back and have them 6 feet apart, but following the other guidelines, hand sanitation, making sure kids that are sick stay home, wearing their masks. We do believe schools, as much as possible, should be open, and this is a good thing, but we do urge schools to continue to follow the guidelines. CDC put out, as I think y'all are all well aware, has put out some nice guidelines, and we do recommend that schools follow those.
Okay, our next question is going to come from Nicole Foy.
Sorry about that. I still have my hand up.
Oh, okay.
Nikki, you got muted.
Oh, sorry. It looks like Kyle Fonensteel has his hand up for another question. Kyle? Looks like you are muted. I'm going to unmute you, see if that helps. I can't unmute you. Here. Maybe you can add your question in the chat, Kyle. Sorry about that. I'm not sure what's happening. We'll move on to Melissa Davlin.
Hi, Nikki. Thanks. This is sort of related to COVID, but the House just voted down the Idaho Department of Health and Welfare's welfare budget, and I was hoping to get a comment from Director Jeppesen about that.
Director, I'll let you answer that question.
Okay. Well, clearly I've been away from my newsfeed too long because I was unaware of that. We'll have to, we generally don't comment on active legislation in the House. The House is the legislature are the policymakers. They're the ones that pass debate laws, including budget appropriation bills. And so we'll need to follow up and see what the concerns are and what the next steps may be.
Thank you, and sorry for springing that on you.
That's okay. Thank you.
All right. It looks like Audrey Dutton maybe this will be our final question here from Audrey. She's got her hand up again, assuming mute is working or not working.
Yeah, I'm the kid who's keeping class late, but I wanted to find out if you can help people understand what they should feel safe doing right now. I know this is a huge question. What are some safe assumptions at this point for the variants? Can people assume that they're circulating, or what kind of assumptions can we make? Dr. Hahn.
Oh, been called out, Dr. Hahn.
Yeah. Audrey, can I just ask, are you referring to vaccinated people or for everybody?
Both. I think both sets of people are wondering what they can do in light of the variants right now.
Yeah. Okay. Thank you. Yeah, I actually had as a backup slide. I really do like, and maybe Nikki, I will ask if you could let me share. I just had I think a really nice graphic from CDC. Well, okay, I'll just move. I'm going to try it myself.
I think I just moved it. I moved you. You've got the ball, Dr. Hahn.
Nice. Okay. Oh, and of course I have it on the wrong screen. Okay. Anyway, I would just like to say, as this is coming up, I think in general, I totally understand. Let's see, do I have the right? Are you guys seeing my screen at all?
Not yet. There we go. All right.
Okay, I think I'm sharing. Here we go. So I like this graphic from CDC on vaccinated people, because it is parsing out. Sometimes it feels like we're parsing out nuances, and that's kind of hard to remember. Okay, wait, there's 2 people here, and I'm, this is a nice summary from CDC about what is recommended for, or what is considered to be okay if you've been fully vaccinated, and what we still recommend you avoid doing. So certainly we are still recommending to everybody that they do not attend large gatherings. As you know, in Idaho, we still have the order for 50. And actually, this has come up a few times recently when questions come up about graduation ceremonies or things like that. You know, unless sort of an exemption is applied for, we do recommend not being in large gatherings. We also recommend not assuming anybody, if you're around unvaccinated people, remember they're still at risk, and you want to continue to be very careful with them, wearing masks, keeping your distancing, etc. However, for vaccinated people, even with the variant, we do want to give people a feeling that, you know, there was benefit to being vaccinated, not just for peace of mind, but also in how they can live their life. So I think this is a nice summary of that. For people who are not yet vaccinated, we would say to hold the course, and even these activities listed here should be avoided. You'll note that with the travel, Elke already talked about that. It's a challenging message. Travel is okay, but we recommend you avoid non-essential travel. So the kind of travel that I think CDC and we are trying to encourage people to consider doing once they're vaccinated is, for example, potentially visiting a loved one that you haven't seen for a year, maybe an elderly person a parent or a grandparent. There are some things once you're vaccinated and they're vaccinated, we want you to feel free to do. Nonetheless, I hope that's helpful to you. I thought this was a nice graphic, just sort of saying, yeah, this is the kind of stuff that we think once you've been vaccinated is okay, even in light of the variants. But we do recommend, you know, I'm fully vaccinated. I know most of you all probably on this call are by now. I continue to wear my mask. I wear my mask when I go to the grocery store. I continue to wear my mask when I'm around non-family members, unless I'm outside or in some setting where I feel secure. So it's really a challenging time for all of us.
All right, thank you, Dr. Hahn. I think that's a good place to end it today. We are out of time. We are planning another media briefing at 2:30 p.m. Mountain Time next Tuesday, April 13th. You can watch for those details on Monday, and thank you all for joining us today.